Hello and welcome to another episode of the Young Tongues podcast. My name is Barbara Fountain and I am the founder and CEO of the Young Tongues, a global peer-to-peer support group for young tongue cancer patients. Welcome back to another episode. Thank you so much for joining us. And I'm really excited because we've got another fabulous guest, an expert this time, who I've had the pleasure of meeting with at a conference earlier in the year. So please, I would like to welcome Professor Camilla Dawson, speech and language consultant. Camilla, it's lovely to have you here.
Thank you so much for inviting me. I'm so excited to talk to you because we had such a great first meeting when we were in Amsterdam at a conference, and I've been really looking forward to this.
Yeah.
So thank you very much. It's a real privilege to be asked.
Yes, no, same here. We had so much banter. It was so fun, and I was like, "You need to come on the podcast." So, Camilla, we always like to start with the same question because we like to get to know everyone beyond their profession beyond the profession. So can you introduce to everyone who is Camilla?
Okay, so I'm Camilla. So I work in Birmingham, obviously as a speech therapist, but beyond the speech therapy bit, I really enjoy keeping fit. I really enjoy travel, but mostly for me, just being out in kind of the mountains or by the ocean, just big open space is my thing. So I'm lucky enough to have a honorary position at the University of British Columbia, which is where I did my postdoc. And so when I get to hang out in Canada and see whales and orcas and baby seals, which I do a bit of work with sometimes, that's my really happy place. So that's what I like to do. And just being active, meeting people like you. I really enjoy, talking about new things, challenging myself. Those are the things that I like doing outside of work. So yeah, that's a bit about
Sounds
me.
amazing. Oh God, getting the ability to go to Canada on a regular basis must be really, really exciting. So how did you get into speech and language? So what drew you to the field, and what was your pathway basically to where you are now?
So I grew up in mid Wales, and when I was thinking about things that I was going to do at university, there were lots of different options. I was quite creative, but I also really enjoyed science, and I wasn't quite sure what I wanted to do. And my brothers and sisters and my parents do various different jobs, but my mum's a midwife, and I wasn't quite sure about what I wanted to do. And it might have been medicine, it might have been arts-based stuff. So she suggested that I went to work as a healthcare assistant for my year out to really understand what the basics of healthcare were, because she was a nurse and then she was a midwife. And it was when I was working as a healthcare assistant, trying to understand what I was going to do at university after my A levels, that I thought that medicine might be something that I did want to do. And then I got to see a speech and language therapist working with a person who had really complex swallowing problems and tracheostomy. And I just remember thinking that there was a really special, really precious thing that happened in this interaction between an individual who couldn't communicate and couldn't swallow with this specialist that understood about what that looked like. Beyond medicine, there was this, I just really recognized early on this kind of bridging the gap between medicine and psychology, really, in that circumstance. And I just thought it was the most precious, wonderful thing. And and that's how I got into it. So then I studied it in Leeds, and I knew then that cancer was what I wanted to work in, absolutely from the get-go. And so I studied in Leeds, and I got a placement at the Queen Elizabeth Hospital in Birmingham, where I am now.
So to become a speech and language therapist, do you study medicine, or is there a specific course for speech and language therapist?
No, there's a specific course. So it's you can do it as a postgraduate or an undergraduate. I did it as an undergraduate, as a BSc, so a Bachelor of Science. So there's a lots of medical disciplines within it. So it really ticks that kind of medical box for me. At the same time as there being lots about psychology and applied linguistics. So you work as you do your undergraduate degree, and then you specialise afterwards in paediatrics or adults, and then further on with airways, dysphagia. Some people work in stammering, lots of different things. So from the get-go, I then got into cancer.
Because that always fascinates me, because we think of speech and language, but there's so many disciplines within speech and language and experts within that as well. So, because quite often it depends what our experience is, but quite often we don't actually have that many touch points with speech and language, which always seems a bit country, or we only meet people in one specific line, and then we think, oh, that's what speech and language is. But actually, there's lots of different colour, I guess, to the job.
Yeah, absolutely. And when I first started here in Birmingham, it was around the time of the Iraq and Afghanistan war. So actually, my first foray into speech language therapy was about blast injuries and working with people who have big war based injuries, because I was working at Selly Oak Hospital, because I'm old enough to have been around then. But so yeah, for me, trauma and critical care and head and neck cancer has always been the thing that I do. But you're exactly right. People work in the youth justice system. They work in, stammering through to neonatal work. There's a huge amount that speech therapists do. And I'm totally biased, but I think it's the most incredible job. And I think when you get it right and you have that really unique, precious relationship with someone who is compromised from a swallow or communication perspective, it is the biggest privilege. It's the most amazing creative relationship. And it's also something that I feel really passionately about doing well. So it's really lush that I get to talk to you about this stuff, because I'm really driven by it. And I think you and the community that you've so capably and eloquently created needs to be the thing that informs how we do this well. So it's just such a treat to be here talking to you about it.
Thank you. No, and that's really true, because I guess that's one of the observations, and that we chatted about when we saw each other in Amsterdam. I said it's what I find really interesting in seeing all the different posts. We have some patients who, well, including myself, who met a speech and language therapist once in hospital and was like, oh, you're fine, you're functioning, bye-bye. And then we have other people who we've had someone who's in between two NHS trusts, which means they didn't see a speech language therapist at all because it got forgotten. They didn't know they need it until a lot later in their pathway when it was flagged. And then we have other examples where someone has someone dedicated working with them nearly through their entire experience. And then obviously there's the other point of once late effects take hold after treatment, that people with dysphagia or speech impediments then start working with speech and language therapists as well. So there's a multi-pronged viewpoint here. So I think I'm going to put you on the spot now, Camilla, sorry. From your point of view, and I guess in your own personal opinion, what do you think best practice would be for, let's say, the hospital part? Like if you get, or even no, I don't want to get just for after the treatment, after the surgery has taken place, what should we expect as patients?
So I have to mention that I am a national clinical lead for Get It Right First Time for NHS England, which is a programme about exactly what you're talking about, which is what we call unwarranted variance, which means that there's someone in Norwich that might get a different outcome to someone in Birmingham, to someone in Newcastle. And that's what can't happen. You need to know when you go to a surgical centre for treatment that you're going to get the same quality of intervention from your surgeon, from your oncologist, from your speech and swallow therapist. That's what your assurance should be. So we're working really hard at the moment to define nationally what those guidelines look like, and to say that people need to be held accountable for it. And sometimes it's about money, and sometimes it's about recruitment, but sometimes it's about people not knowing what good looks like. So we're working really hard to say what good looks like. So I'm really glad you've asked, because I'm really opinionated on it. So what good looks like is, number one, meeting a team beforehand, before you have your surgery. So you meet your surgeon or your oncologist. Let's go surgery first. And you know what the person is going to do to remove tissue in your mouth that's cancerous, how they're going to put it back together. And then to meet the team around you, which are going to be a clinical nurse specialist, a dietitian, and a speech and swallow therapist or speech and language therapist. I say speech and swallow because a lot of this stuff is about speech and swallow rather than language. And so that they sit you in a room with your loved one or with someone that cares about you and you care about, and they talk about what's going to come next. Now, we know in that session that your head is totally smashed and your ability to understand what we're talking about is pretty much zero, because what you're thinking about is, am I going to die? And if I don't die, what's my life going to be like? But we know that if we meet you at that point, at least you've got a face and a name and some sort of sense of what might happen when you're having surgery.
Mm-hmm.
When you have surgery in the hospital, we like to meet you here. I can tell you what we like to do. We meet you on critical care. So when you're just groggy and you've got a tracheostomy, you're totally freaked out and you don't know what's around you, that your speech and swallow therapist will come and see you, and the physiotherapist as well, if you've got a tracheostomy, to come and talk to you about your breathing, your swallowing, your shoulder function. Then when you get onto the ward, our incredible ward nurse teams are obviously with you all day, every day. You see your ward round every day from the surgical team. And here the speech and swallow therapist is part of that team. So we'd see you every day on your ward round. And then we'd see you after the ward round for therapy about establishing your swallow and your communication. But a really big bit of what I do and what the incredible team here does, I am totally biased, like without a shadow of doubt, is that we talk about how you're coping, and we talk about what it feels like when a bunch of people who are dressed and have got makeup on and smell nice come and talk to you when you're in your pajamas in your bed and you can't talk and you feel absolutely freaked out because all night someone's been checking your mouth, you haven't slept, there's someone next door who's really loud, you don't want to use the bathroom, you're sweating and stuff's dripping. And actually sitting and talking to you and saying, we're here with you. And we're not just doing to you, we're talking to you about what recovery looks like. And we're saying to you, it's normal to feel totally out of it. It's normal to feel so frightened. And yet to have dropped the adrenaline that's kept you going, that's telling you you might die. So that drops off and then you're just empty, because it's the adrenaline that gets you into the hospital. Because let's be clear, everyone has a choice, but really you don't, because if you don't have surgery, that's palliation and that's dying, and that's a really big deal. And so actually when you're here, suddenly the adrenaline's dropped off and you just feel totally flat. And we're coming and saying to you, everything's looking good. How are you doing?
Yeah, that resonates. Like everyone's like super, you're doing really, really well. And I'm like, am I? I look like I've had a car crash.
Yeah, and the flap's looking good. And you're like, what's the flap?
Yeah.
What are you talking about? What's looking good? Because I'm feeling dreadful, mate. And on the one hand, it's right that we're saying to you, we're really pleased with your recovery. But also the piece of work that's really important, and this speaks to what you're saying, is that we sit with you as swallow specialists and communication specialists and say, yeah, you're in the eye of the storm. This is really tough and we're here with you and it's going to get better. And these are the things you can do. And our real aim, if we do this really well, is that you forget our names, but you remember that you've seen us. And actually what we do really well is support you to feel like you again. And not a new normal, because actually, no, it's not a new normal. It's nothing, none of it's normal. And so I'm not a massive fan of the phrase, but with the new version of yourself that you didn't choose, that you have self-efficacy, that you have a sense of ability to hold what you need to, that you've got choices, and that you feel safe in what is now a body that's limited by the surgery rather than limited by you yourself, your brain. And that's a really hard thing. So if we do this well, you forget us, but you start to feel more like the new you.
That's brilliant. I mean, thank you so much. Honestly, I just want to listen to you now. I just want to step back. That's amazing. What do you think the contact should look like after the hospital? Because I can't remember. I want to say I can't remember, but I'm 99.9% sure I never saw anyone again once I was home. That was sort of it.
Yeah, so I think, like all of these things, it needs to be tailored to the individual. So I think some people are going to need, and it's not about the size of the scar, it's about how you're feeling. So some people are going to need a significant amount of speech and swallow therapy. So here in our centre, there's no limit to what you have. You don't get 2 or 3 sessions and that's it, because that's not fit for purpose. But there are some places that are limited by funding and capacity that have to say these are our limitations. And that goes back to the work I do with NHS England to say we need to make sure that services are equitable. But actually checking in with a clinical nurse specialist, with a dietitian and a speech therapist after your surgery is a really useful thing. And that might be, if you're doing really well, at the session you have with your surgeon, that we all trot in, ask how you're doing.
Yeah, that did happen actually. I just can't quite recall because it's all such a whirlwind of appointments.
Yeah. Although you do remember that you didn't see someone. So there is something about that is actually, I think I would have liked to have seen someone. And I think some of this is about debriefing too. So some of the research that I did early on in my career for my PhD was about what people need post-surgery. And there was a big piece that was about people emotionally processing and physically processing what went on. So it's easy to say, oh, I'm not swallowing and I'm choking. That bit is an easy referral to someone. But actually the bit about, I'm a bit socially isolated now. I don't really want to go out. I'm not sure that I feel comfortable seeing my friends and family. That stuff is more subtle. And I think it's in those circumstances that engagement with teams to provide therapy on how we can support you psychosocially is really useful too. But I think knowing that the speech and swallow therapist is the person you should be seeing if you are having problems with swallowing, if your communication isn't what it needs to be, if you are feeling socially isolated, asking for that referral is something that you can do as well.
Absolutely. This is just a question that sort of popped up from the community. What we have quite often is that people are working with speech and language therapists and they're giving exercises to do. And, you know, anyone who's ever pulled anything and has seen a physio and then goes home with exercises, and let's be honest, I don't know how many of us actually end up doing them as rigorously as we should. But we always get a sense of frustration within the community bubble up about this not seeing an instant payback, not instant progress. What would you say to a patient who's listening, who can communicate absolutely fine, but feels self-conscious about the way they sound and also feels they are not quite where they should be with the pronunciation, articulation of their speech?
So I would say what you're feeling is exactly right, first and foremost, because it's yours. And the big thing about what we all do is our communication is our sense of self and our identity. And so the way you present yourself is absolutely your sense of identity. So when it's not working right, your identity is compromised too. So first and foremost, saying to your surgeon or oncological team that you want to see the speech therapist is absolutely fine. That is never a problem. The second thing I'd say is that we've got some really great research that talks about what swallow and function looks like. And actually, things don't happen quickly in your mouth and your throat. And what's really important is that we recognise that 7 weeks, 14 weeks, 6 months, these are all, and a year even down the line, are all times that you continue to see change. Now, it's dead subtle because what you don't see is like when you're doing, apparently I wouldn't know, but when you're doing abs exercises, that you can start to see a six-pack. You don't start to see your pharynx improving. You don't start to see your tongue moving better necessarily. But actually, these functional movements, some of them are passive. So some of them aren't about, like when you go to the gym, you're lifting weights. Some exercises we give are about resistance and volume and frequency. Some exercises are about passive movements that mean that you're stopping the fibrosis that we'll go on to talk about, I'm sure, which is late effects. So using it and stretching out muscles is really important. But then if you've got specific weaknesses, it's doing increased frequency, load and resistance. Those are the things that make a difference to strength. So strength and efficiency of swallow are two different things. So the strength of your swallow for all of the different muscle groups, be it throat, be it tongue, be it palate, all of that shenanigans, is different to the efficiency of your swallow, which is when I put something in my mouth, I can get it from my mouth to my throat to my stomach without coughing. That efficiency is different to the side of my tongue, which is now a bit of my arm, isn't as strong. And so we need to target those muscles and that science differently. And so seeing someone like a speech therapist to say, I'm thinking about strength because I get halfway through my meal and I just can't go any further. I'm so fatigued. Versus when I'm swallowing halfway through, I am coughing to heaven and I don't know why. That's about efficiency and safety. So working on those things separately with your swallow therapist is really important, but persevering with it because it's so subtle. And you're never going to see abs on your tongue, unfortunately.
No.
But in doing it, there's a lot of work that says if you disuse atrophy is the phrase we use. So not using it makes all the muscles weaken. So making sure that you do it and overdo it and overdo it is a really important thing, even when it feels thankless, when it feels like you're getting nowhere, and actually that it's just useless. We do know from research, specifically stuff, there's a study by Giselle Carnaby-Mann called Pharynga Size and the McNeil program that people might have heard of, that's about rehabilitation after chemoradiotherapy. And we know the more you use it, the thicker the muscle gets, the more efficient your swallow gets. So it's definitely worth it.
Absolutely. I wanted to come on to that next. So we've spoken about surgery. Most of us go on to have radiation or chemoradiation combined. What does good look like in those situations leading up to radiation? So in that in-between time from surgery to radiation, and then during treatment, which is the most brutalest of times, and the couple of weeks after, through to that recovery healing stage in the first 3 months, 6 months, 12 months out of treatment.
So again, you should be seeing someone before radiotherapy to talk to your clinical nurse specialist, your dietitian, and your speech and swallow therapist before your radiotherapy, sorry. You should be talking to them about what's to come. And in some of those sessions, they might talk to you about a feeding tube into your tummy or via your nose, depending on what type of surgery or what type of tumour you've got. Because sometimes we know that the type of tumour you've got, if you've had it removed already, then some of the muscles, as we've just talked about, may not work enough for the absolute onslaught of radiotherapy to the muscles and the skin of your throat. So sometimes having a feeding tube proactively is a useful thing. Or if you've got a tumour there that is being treated primarily with radiotherapy, sometimes the tumour and the back of your throat gets so sore that what we want to make sure is that you've got a feeding tube so that you've got adequate nutrition and hydration, because the one thing that's going to get you through it is making sure you've got decent nutrition and hydration. So you should be seeing people then. Usually you'll see people from kind of week 2 on radiotherapy in most centres in the UK. And as I say, I'm speaking as me rather than me in my guise of different roles, but usually you'd see someone from week 2 or week 3 in radiotherapy from a speech therapist and dietetic perspective, and usually a clinical nurse specialist and your oncologist, at least usually weekly, to see how your neck's healing and everything else. After radiotherapy, we usually give you a couple of weeks break because you've had it up to here with the hospital and clinicians and talking to people and getting in your car. So
Yes.
A couple of weeks just to not have to placate anyone and talk to anyone is important for you to just rest. But after that, usually we start to see you quite frequently after that. So up to 6 weeks, we'd be seeing you kind of as frequently as you need it. And then after that, I think a lot of it depends. There are some really good studies at the moment that look at what the best follow-up is, because ultimately the answer is we don't know what the best follow-up is. There's a really great study by a colleague of mine called Paul Nankivell, who's an ENT surgeon and an academic. And he's looking at something called PET-NEC2, which is about what the best follow-up is for patients. What works best? Is it about you telling us what you need from us? Is it about us training you as to what's concerning to get in touch with us? Or is it about structured stuff that we can do that says you come in every week? Because one of the things that is a really bad thing is if we over medicalize you. So if we're saying you need to come in to see us when you're actually just getting back on your feet, what we do is kind of undermine your ability to do this stuff by yourself and to be okay. And we overdo it with, we're still here. We're you know, we're kind of the ones in control. Because all of this stuff through your treatment lots of it is about a giving and relinquishing and giving back of control.
And sometimes it is a bit like needing a bit of a
Yeah.
gentle push, and realizing, oh, I can actually do this by myself. So yeah, no, I totally see that. Yeah.
But it's a balance, because actually, if you're feeling really vulnerable and you're just holding it together, and part of how you're just holding it together is coming in to see the team to feel reassured, that's different. And that's why this has to be person centered. And it's really in the skills of us building relationships with people with cancer to say, what does this look like for you? Because these are some of the things moving forward. Because you'll get to a stage where your swallow's been optimized for the point that you're at, or your communication's been optimized, and you need to do stuff at home, like you were just saying,
Yeah.
to really make it better. And so if we do it well, we say, this is what it looks like. If it's not working or you hit a wall, get in touch. This is, we can restart this.
Yeah.
And I think that's probably where the late effect stuff comes in.
So I wonder if this question's going to set me up for late effects, but is it totally possible that someone has surgery only or surgery and radiation, and they are absolutely fine, doing loads of progress, and suddenly they have a setback where they have incidences of choking whilst eating, or the swallow changes, their speech changes, like, because sometimes as patients we think of recovery as linear, and the first learning curve we have is not linear. So is that something that can happen?
Yeah, it can. And actually, especially after radiotherapy and chemotherapy, the muscle itself changes. The muscles in our mouths and throats change. So actually, suddenly you can be doing okay and fine, and you can get a really nasty infection, or you have to come in to hospital to have a hip replaced, or because you broke your leg and you get intubated, and suddenly your throat just isn't working as it was before. And there's no rhyme or reason other than sometimes it is an intervention, like we've intubated you, or sometimes it's because you've just hit a point where your function, you've hit a threshold of where you were coping and suddenly you're not now.
Mm-hmm.
And that is just about all of these complex muscle groups that usually work together, suddenly not being in competition rather than working together. So sometimes people find if they've had a really bad chest infection, their ability to swallow easily is really difficult, because actually breathing and swallowing doesn't happen at the same time. So if you're struggling to breathe, it's really hard to swallow. And so if you're finding those issues, I would encourage going to your GP and saying, actually, I need a re-referral to the team, because after 5 years, that's one of the tough things, isn't it? Is that you're not under the care of the head and neck cancer team anymore.
Well, most of us stay, because
Okay.
yes. So from a lot of chats that we had, because it seems to be because we're younger, I think our consultants are quite happy to keep us on the book. So I'm still with, I said to mine, I'm sorry, you're going to retire with me. You're not going to get rid of me. But it's more that the whole reason for it is so I have easy access.
Yeah.
Because we've also, within our community, have seen recurrences after 5 years. So I think because we're now, as a community, becoming more aware of that, we're like, well, we just want to keep the access to you. So whether we need it or not. So we can either go via refer, but I guess sometimes with speech and language, it is easier to get a re-referral via your GP than trying to get hold of your consultant when you're not seeing them on a regular basis. So
or so the GP can do it, or I would suggest that actually if you got in touch with, I'm trying to think, if you got in touch with your, consultant secretary and said, could you let my consultant know that I'm having some problems with swallowing? Actually, none of our consultants would say that's a problem, and, we'd get to see you.
Yeah.
And I think it's really important, because sometimes I think we say to you in sessions when you come and see your surgeon, how's your eating and drinking? How's your weight? And you're like, yeah, great. And actually it's like, oh no, I've had a subtle problem with my swallow, actually, that's been complex, but it's such a stressful situation a lot of the time, because you're worried about recurrence when you come in, that it's not easy to go, oh, actually, no, can we take a moment? I'm not quite managing dry foods anymore, or I've had this chest infection that won't go, or I don't eat Weetabix anymore, that sort of thing. And actually those are the things that we should know about.
Absolutely. And I do also feel sometimes, from our point of view, we want our surgeon or oncologist or whoever our point of contact is to just focus on the cancer and picking that up. And then it's almost like, oh, where else do we go with everything else? And I know there's some fantastic pilot schemes in the UK popping up for head and neck cancer clinics, so late effects clinics. So now we ended up with the word late effects, which is such a medical word to say, but it kind of describes what it does on the tin. It's the effects that come in after treatment at a later date. What are the type of late effects that you come across in speech and language, and how do you deal with them?
So some of the late effects, and there are lots of different ways in which people, you're exactly right, talk about what late effects are. There's a really great paper by Diane Selstrom that's just been published in Cancer Survivorship or Cancer Care, I think. I'll find it. But that talks about what late effects is. So it can happen at any point after your acute treatment. So some people refer to it after 5 years, but some people say it can happen after a year. So up to you how you interpret it. Essentially, it's any changes to the function of your mouth and your throat as a result of your treatment. So for some people, it will be a really woody neck after radiotherapy. For some people, it will be the ongoing dryness in your mouth. For some people, it will be a sudden change in your swallowing. So where you could swallow before, you suddenly can't. For some people, it might be your palate not moving as well. So your voice becomes more nasal. And so it can be any of those things. It can be wound breakdown as well in your mouth, or osteoradionecrosis. It's any of those things, which is the breakdown of your jaw, or the bone in your maxilla. So it can be any of those things. And essentially, those things may be about not being able to swallow easily, your speech going off a little bit, finding that you're drooling a bit more, or that actually you're producing so little saliva it's really difficult to swallow. Any of those things can be part of late effects. And the things that we do in speech and language therapy for them are really targeting which muscle groups have been affected. So sometimes it might be about stretching up your jaw. That's another one that we see is a really tight jaw that you can't open, that we call trismus. So we can give you little machines that kind of help open up your jaw. There are other machines that can help your tongue base function, so your tongue hitting it against the back of your throat. There are other things that we can do, like suggesting mouthwashes. There are other things, specific swallow exercises we can give you, postures we can give you.
Well, with the swallow exercises, one of the things I always get fascinated by, and some of our patients sometimes put them up on the group and everyone gets really geeky about them, are the videos of the swallow with the camera and actually seeing the function. And a lot of people reported how helpful they've been, because swallowing's like breathing. We just were born with it. I never had to learn how to swallow. So to relearn that, but actually see intrinsically what happens, I guess can really help your brain understand what you are trying to compensate for.
100%. And asking your speech and language therapist to carry out a video fluoroscopy or a fibre optic nase endoscopy or a FEES, fibre optic evaluation of swallow, those can be really useful things so that you can really see what's going on. And as you say, that feedback that is, when I do this, that's what's happening. And especially when you're undergoing those nase endoscopies, a lot of the time with your surgeon anyway, if you've had swallowing problems, just saying to the surgeon, can the speech therapist come in to have a look? Is there anyone around to come in to have a look at my swallowing at the same time? All of this is obviously within the guise of what is in the UK a publicly funded service, and obviously it's more complex across the world when you're paying for things. But just coordinating that care and asking the question, there's no challenge in that. And you're exactly right. It's great when you can see it so that you can really understand what it looks like.
Yeah, and I remember someone going, I can't remember exactly what their difficulty was, but it turned out that for some reason, something probably in the surgery, but that some small amount of liquid was actually going in the wrong place. And that picked it up, and they were like, for a patient, sometimes we think a lot of it is in our head because we can't see it. It's not like it's a bruise on your forearm and you go, look, it's this. So to then go, so it wasn't in my head and that's what it is really helpful. And then also really hopeful, because then okay, we know what it is, now we can treat it.
100%. We always start our video fluoroscopy clinics when we're seeing patients people with head and neck cancer or have had head and neck cancer with what you're feeling, I'm sure we're going to see.
Yeah.
So, actually that validation that you have, you're exactly right, because your sensations changed as well. And you don't know whether you're feeling really anxious because the potential of cancer coming back is there all of the time. And you just have to park that. You just have to live with that. And that is really hard. And living alongside then the symptoms of what is a bit of your arm being in your mouth. That's a really complex thing. Or having had a neck dissection or having had chemoradiotherapy, knowing what is a symptom, what is your perception. Those things are really hard. I would say more often than not, the things that you feel are the things we see. And it's really important that you feel that you are validated and seen holistically with all of the realities of what your treatment are, because they're all as valid. It's just as valid to have real anxieties about what's going on as a really intractable dysphagia that is a real medicalized issue. Just because we can describe one and see one doesn't mean that it's any more valid than the reality of day to day, you having to work really hard to keep things together so that you can get through.
Yeah.
Yeah, that's really important.
Absolutely. And it's those quality of life impacts. So the ones which are really obvious, so we'll all think about and are easy for us to communicate. So a problem with swallowing, a problem with communication, but actually there are other impacts as well, which are probably more personal to us. And I know you're not scared about talking about this. And I wanted to pick your brain a bit because as a community, we've also had discussions that we need to be more open in sharing with each other about challenges with intimacy after treatment. And there's a psychological aspect where, I wouldn't expect anyone to have a high libido after surgery and chemoradiation. So it's finding your way back to that, which is one part. But the other part is actually a very functional, practical part, is how do you deal with not having any saliva or having too much saliva when you're trying to be intimate with your partner. And again, different communities within our community, so be that straight people, people who are gay, or different identities, whatever it may be, everyone has a different impact. So how much have you come across this in terms of having conversations with patients in clinic, and is it still a taboo, or do you find like younger people are starting to open up more about it?
So I think it's really a taboo. I think it's a really difficult thing because I think as humans, it's a difficult thing to talk about intimacy anyway. As a community of head and neck cancer clinicians, we're all really aware that we don't do a sufficient job when we talk about intimacy, because I think it's really, really personal and it's really difficult to talk to anyone about this stuff. It's difficult to talk to your friends about it, let alone someone that you don't know their beliefs or perceptions. When we work in the roles that we do, you don't know whether it's going to feel uncomfortable. It definitely will feel uncomfortable. And so we don't do a good enough job. And there's someone called Cheridith Semple, who's an amazing clinical nurse specialist that writes about this. Now, so I don't profess to be an expert in this, but I do think it's our role to really speak to what intimacy is. So the first thing that I would say, and this is what I would say to patients, and as I say, I'm talking to you as, in with my experience clinically, but outside of my professional roles, I think that's so I think what's really important is that a lot of the time, and I spoke to this before, unless you have a chronic health condition, when you get a diagnosis of head and neck cancer, you're suddenly defined by the limitations of your body as to what you can do. Whereas throughout our lives, if I don't want to get up and go for a run, it's because I've decided not to. And that's fine. But when you physically can't do it, or you physically can't go and just grab a drink or go out with your friends easily, that's totally different. And really surfacing that tension about, oh, I used to be able to do this and I can't, is a really difficult thing, number one. Because on the one hand, if you really lean into that, that's a really tough thing to say, actually, my body defines me now, and that's hard. And I can't hide it, and I can't not tell people about it. And the other side of that is, if you don't surface it, what you find is, I think that you can pull back from relationships, be them intimate or just personal relationships with people. So just as you wouldn't go out for dinner with people because it's awful to think about how you have to say to the waiter, but can you blend that down? So you know what, it's just easier, I'm not going to go. Just as in a physical or intimate relationship, actually having to say to your partner, I don't want to do this, or this is difficult, or I don't know how to manage this, really takes away from the spontaneity and the choices that we all might have in an intimate circumstance. And I think one of the first pieces of work that we can all do is thinking about, actually, what's the problem here? What are the things that I'm worried about? And it's a really hard conversation, but outside of the eye of the storm, or, an intimate moment, I think having discussions with our partners that is, my swallowing is really difficult. And sometimes when I go to kiss you, or when we're talking, and if I'm dribbling, that is really embarrassing for me. And I don't feel like I want to then have, a physical moment with you. That's really hard for me. My confidence is really low at the moment. And it's really hard to have that conversation, but surfacing that so that the person that you're with recognizes what you're dealing with, because you will hide it and you will manage it beautifully, because that's what humans do. But actually saying to someone that I feel just so anxious. I feel so worried about this. I feel so alternate to where I was. Just that discussion takes away the, oh my God, I'm not the same. And I don't know whether, number one, I can be the person I was before. And number two, whether my partner is going to be okay with how the new me exists. So I think having that discussion is really important. I think when you've identified what you're really worried about, be that saliva, lack of saliva, be that the way your body works, because sometimes, after surgery, our bodies don't work in the same way. They hurt and they're sore and we can't move in the same way we want to. Actually, really understanding what that looks like and then engaging with people that can help you with it. So if you've got excess saliva, actually talking to a speech therapist about how you can manage your saliva. And I'm not giving ultimates here, because there are different ways that you manage saliva. So if it's too sticky, you do something to it. If there's too much volume, if it's too, if you've got a really dry mouth, you might do something different. But I do think really recognizing what the problems are, surfacing them, having those discussions that feel so difficult, and really understanding what those look like interpersonally, and then recognizing which individual you might go to in the team to say, would you be able to help me with this? Because I'm really struggling with it and it's personal. And I think a way to open a conversation with professionals is, I'm really struggling to have this conversation, but I want to have it with someone. Can you help? Because I think that what that does is let someone know that you've really thought this through and that you need them alongside you. And we do things really well as healthcare professionals if we are alongside you and not just doing to you. And I think sometimes having those discussions is where the solutions sit for some of those things about, my body's different and I don't know how I can manage my altered self in this specific circumstance, which is intimate and personal and private. And it's hard.
And I totally agree, because I can also see, like, in our community discussions, when people open up and share, what we can do is cut down the loneliness and isolation, in terms of you're not alone. There is actually lots of people who struggle with this, and it takes away a bit of the shame that comes with sexuality, always, unfortunately, somehow, and opens up the dialogue. But I think where we're a bit hampered in as a community, because we're all kind of talking about this for the first time, no one really has the solutions, and then it dampens down. The conversation ends because we're like, well, we don't really know what to do now. But actually, maybe those conversations in the community help broker and open having those conversations with healthcare professionals who can help in a more practical sense, in terms of how to manage certain aspects of whatever it is that is holding you back from having those experiences.
I think so, because I think some of it, so Macmillan do really great work as well on sexual function following cancer, but I think the head and neck cancer piece is a really specific one. And I think sometimes being able to have the conversation, even with yourself and with your community, but with your partner, and then, as I say, being able to say to someone, this is what I think the problem is really important, because I think then being able to recognize how that sits alongside your sense of, as I say, your altered self, is a really, really big deal. And it's a really important part of your recovery as well, is being in circumstances that are about your choices and your sense of, identity. And those bits about how being alongside someone in an intimate circumstance is about your recovery and about feeling like you. And when those don't happen, that can really compromise your sense of recovery too, and your sense of isolation. And some of the work that I did in my PhD was about the transition post surgery, what people needed from us. And people talked about something called liminality, which is it's reported in the literature. So people told us that they were in a transitional phase. They were neither who they were nor yet who they were going to be. They were in this, what the literature calls betwixt and between, or a place between opposites.
Okay, yeah.
So it's being on the threshold of something. So it's a phrase that's used in anthropology or sociology, so the study of people, and it goes back thousands of years when like people would go into the desert and go leave a child and come back an adult, or people have used it in talking about divorce or death. But it's about this place, this place between opposites, being on the threshold. And I think when you've had a cancer diagnosis and or treatment, this liminal space, this not yet where you were nor yet where you're going to be, is a big deal. And actually everything exists in that. You exist there as a partner, as a daughter, son, as a human that's in a partnership with another human, regardless of your sexuality, orientation, cultural background. You're sitting in a place which is new, and trying to orientate your function amongst that when it's so public to the world, when it's so dependent, when your job's dependent on it, is really, really hard. When everything you do is dependent on how you present yourself, then it means that you have unique requirements from us. And I think we recognize those, and the better we can be and you can be at saying, I think this is what my problem is. Because saying to someone, my relationship's not working, that's quite a difficult thing, because actually there's lots of bits of all of our relationships that work and don't work. But being able to say, actually, I think my sense of vulnerability with regards to my intimacy, sits within X, Y, or Z, means that we can start to talk to you about it, and sometimes help you understand what that looks like. But I think having those conversations and destigmatizing it is really fundamental, because there's a huge part of recovery and sense of self and identity that we miss otherwise.
Oh, Gemma, thank you so much. That was just so fantastic. Thank you. Now, I'm going to go slightly off-piste, because
More off-piste.
More off-piste, I know. Well, what I meant, like quite a change in tone, and actually come back to why we met in the first place.
Yes.
So we met at this conference, and I went to your presentation, and I just went, wow, I like this woman, and I really liked what you were presenting on, which I was like, oh my God, yes, like, how are we not all doing this? So I'm not going to give anything away, but can you tell the young tongues what your presentation was about, and how your research fed into that?
I can, yes. And thank you very much for saying that you enjoyed it. But so my presentation in Amsterdam was at a European Head and Neck Cancer Conference, and we were talking about prehabilitation. So what you do before surgery or before radiotherapy to really optimize swallow outcomes. So lots of people would have heard about things like ERAS protocols, and that's about enhanced recovery after surgery. So you can do it a lot for, like, it happens in thoracic surgery and urology. And in head and neck cancer, there are some things that people are suggesting would be really useful. So that's things like getting trachees out quickly. It's making sure that you're well nourished before surgery. It's those sorts of things. And one of the challenges for us is that we don't know what that looks like specifically for head and neck cancer in the same way that we do for a hip replacement, for example. Because everyone has a different cancer. in a different location, of a different size, invading different muscles. And we're all sicker, weller, thinner, heavier, have got better or worse social support. So that's what we call in research variables that mean that saying, right, the ideal thing for someone with head and neck cancer is this: do this 8 times a day, you'll be great. That doesn't quite exist. So the other bit about this is that what we expect from you psychologically post head and neck cancer, because everything is so public, like I was just saying, means that we need to have a two-pronged approach, which is making sure psychologically you're ready for what's going to happen, as well as
Which
your body.
which most of us listening will probably be going, yeah, I wasn't. So yeah, no,
Yeah,
I think
no.
none of us were. Yeah.
I don't, and honestly, this is another bit of my research. People said I don't think I ever could be prepared. So to be
Yeah.
honest, actually, it's useful to know stuff. Don't get me wrong. We need to meet you and talk to you about stuff. But the preparation for this existential change in yourself, I could never say to you. Because honestly, if I did, number one, I'd probably be wrong, because what do I know, because I'm not you? And I'd be an idiot to say I know what's going to happen to you. I can say to you, I've done this for a while, I've got a fair idea that you're going to have X, Y, and Z happen, which is what we do in pre-treatment. But if I said this is exactly how you'll feel, you'd think I was an idiot appropriately,
Yeah.
because you'd be like, how dare you?
Yeah, and actually it's the same with young tongues in terms of so before young tongues there was no information available outside of the clinical area, and other than what was on Google, and don't go on Google. That was the one thing everyone said to me, like, don't go on Google. And then my husband went on Google and he went, don't go on Google. But it also made it really difficult. So I purposefully stayed away from anything on Google because I didn't want to scare the living life out of me, and I wanted to just try and stay as positive as possible. But at the same time, I had the surgery explained to me, and I'm like, my brain cannot wrap itself around it. And then also, the whole risk factors of not being able to speak and all of that, it's a lot to take in. So with having young tongues now, I can see we have like different types of people come in. We have people who come in and go, oh, okay, I like this, but I'll come back when I've had it done and to talk about it and decompress. We have some people who have been diagnosed that afternoon, are in the group by the evening and go, okay, I want to know absolutely everything. And one of the nice things about Young Tongues is because we have this really big community, you get this really big variation of different experiences. So in a sense, I do think, even though I personally think it's an absolutely onslaught of information, but I do think it's actually a good onslaught of information because it kind of goes, oh, okay, so that's the worst. However, there's all of these others. And I think as young people, quite often, not always, we're quite pronged, especially in a fight or flight, you kind of try and see the positives and go, oh. And so in that sort of sense, I can see how that's totally like individualized. But anyhow, I interrupted. Sorry, please.
No, I think you're exactly right. And I'd add to that actually the skill is when you come into our clinic room for us to say, right, what do you want to know? Do you want to know everything? And actually, if someone's hasn't asked you that, it's good for you. It's fine for you to say, can I tell you, I am literally just holding it together now. So give me bare minimum. And I just want to know what to expect, or the things you think I need to know, versus tell me everything. I want to know about anastomosis. I want to know about Dopplers. I want to know about the cuff on the tracheostomy. I want to know about what my fluid, my Waterloo scores. Like, if you want to know that stuff, that's fine. But equally, there's a real skill that we all have after doing this for a while that is, I don't know, I think I've got an idea about how we can do this well. And I think if I overload you, you're going to go home and feel so freaked out that coming in for surgery is going to overdo this for you. Versus, we're here, this is the bare minimum. We're going to take some of your arm, it's going to go into your mouth. It's going to be difficult. We're going to be there with you to every detail. So I think if you can work on, a lot of what I've said is about working on relationships, isn't it? And it's about saying, it's doing that work for ourselves, which is really easy for me to say because I haven't just been diagnosed with head and neck cancer. So I'm not thinking about whether I'm going to live or not. And so my ability to say, you know what, I'm going to sit down and think about, what's best for me. That's easy because I've got the privilege of not being in that circumstance. But what I would say is, if you can take moments to think, oh, I really want to know the detail because I'm freaking out, versus if I have detail, I'm going to freak out. Just taking a moment to think about what's best for you is a really useful thing if you're at the start of the journey that's ensuing.
You know what is the most traumatic thing that comes up in our groups that people didn't expect? It's the trike. It's waking up to the trike. And we've done a little experiment, and this is totally anecdotal and not scientific at all. But one of the things that we've picked up on is, especially in the early days of Young Tongues, when nobody had access to Young Tongues, and I was starting to do these educational posts, and I would go in the group and ask them about a specific thing. And basically, biopsies and trikes come up as the biggest reaction. And the thing that we got, what I really asked is like, well, in what way was it terrible? And it was always described as, oh, I thought I was going to drown. I didn't realise this is what it was meant to do, and I couldn't speak, and no one explained to me that what I'm going through is normal. And that's a message we've heard consistently. And, you know, some people, also the other problem is, or challenge is, some people know they'll have one, and others may not have one, or like with me, they said, oh, you might have one. If you wake up with one, don't panic, but you'll know about it, kind of thing. That's all I knew about it. Hence, when I had this very adverse reaction from the community, I was like really shocked. I was like, oh my God. But what's really interesting now, that we are having patients that are coming in earlier and getting this information. And it's always funny because people ask, oh, I'm going in for surgery, what do I need to know? And it's the ones who've had a trike will go in and say, you need to know, if you have a trike, it's going to feel awful, but it's normal. And then they quite eloquently describe these horrific things, but because you know what they are not so horrific, if that makes sense.
Absolutely.
And we've just recently, actually last week, had someone on the podcast who had a trike and went like, oh yeah, it was absolutely fine. I don't know what everyone was on about. And I was like, yeah, that's because you knew. That's because you knew what it was going to feel like. So that would be, I think, like from us, like a generalized bit of feedback. That's the piece of information that is probably worth sharing if someone has anxiety, because they're going to be freaked out of their mind.
Would it be useful for me to talk about a tracheostomy now, briefly?
Yes,
okay,
please.
I think I've got one. Can I just see whether I've got one
amazing.
here? Bear with me a second. I've usually got one hanging around.
As you do.
Yeah, I actually do have one hanging around. Okay, so about my person. I've usually got one somewhere. So this is a tracheostomy. Okay, can you see it?
Yeah.
This is a bendy type of tracheostomy, but a tracheostomy. So the tracheostomy is a tube which has got a hole at the front and flanges at the side. These are the flanges, the bits on the side, they're like little wings. It sits in your throat like this, and it's sutured on with little stitches either side. And this bit here goes into my windpipe. The reason we put these tracheostomies in is because after you have oral cavity or laryngeal surgery, you get swelling and sometimes you get bleeding. And that's absolutely normal. But what we like to do is cut out the middleman, which is your voice box, and put this, so the tracheostomy sits below your voice box. It doesn't go into your voice box and it doesn't remove your voice box. It goes below the level of your vocal cords, and it means that we can literally toilet your chest. So we stick a suction catheter down here to suction out secretions that are in your lungs, because after you've had surgery, your lungs can get swampy. And or if you've got some bleeding, then we can essentially suction it out of your lungs. So when this tracheostomy goes in, you're asleep, but when it comes out, you're awake. So all we do is we cut the sutures on either side, and you breathe in, and then we pull it out, and we put a little plaster over the top. And this is what it looks like. Can you see it there?
Yeah.
So it's got a hole down the middle. And sometimes they have a cuff around them. If someone talks to you about the cuff, that's just a little, it looks like a rubber ring, you know, that you'd sit in like I was going to say a pond, but in the sea.
Yes.
A rubber ring.
Like a donut type thing.
A donut, there we go. So it sits around there, and we can we can put it up so that everything sits dead snug in your trachea.
Mm-hmm.
So it's really snug and no air can pass anywhere except through the middle. Or we can drop the cuff, which means we take all the air out, so it's dead slim alongside here. And then you can breathe around this tube. And sometimes after your surgery, we'll say breathe in, and then you'll talk by putting your finger over the end or with a little speaking valve. And that's the bit that people said to us as well. Similarly, I felt like I was locked in my own body until I could talk. And so that's what this is, but it comes out, it's temporary, and it's to cut out the middleman, which is a swampy old lungs, so that you don't have to cough everything into your really sore mouth. And also it's to make sure that we can get everything out of your lungs from the surgery that's a bit swampy.
Yeah, absolutely. And so what we hear quite often, right, the speech sometimes isn't necessarily just that, it's also all the swelling.
Yeah.
And if they've done a very big graft as well, which can be the forearm flap, quite often they do them a bit bigger because they shrink with radiation, so your mouth can feel really full, so you can't actually communicate very well. So we always say when you're packing, get a little whiteboard to write on there. But I think one of the things that people find really difficult in a hospital setting, which can be a very busy environment where there's not, unless you're in ICU, but not necessarily always someone next to you, is to get someone's attention without their voice. And if, we all know that sometimes everyone's buzzing. So who do you go first? When they get a fluid build up. So I think it's that feeling of drowning, but you're not. That's the reassuring thing, is to tell everyone it may feel like it, but you're not. And the sounds of the suctioning, because it's so close. Again, to describe those so you don't get terrified. Because I haven't been through it, it's really difficult for me to describe. But I link it with my first MRI experience. I was in the MRI machine, and at the end, that thing gets so loud, it felt like a Yeti was trying to break in to the tube. And even though I was quite relaxed throughout it, that was the moment where I went, oh, holy shit, what's going on here? Is this meant to happen? Is this machine malfunctioning? It's not so much that we just don't know, is this normal for this moment in time? And the same goes with, pains and aches. You go like, is this pain and ache normal to expect in this time with what I'm going through? Or actually, is this not? Do I need to adjust it? So it's really difficult and really delicate. So I don't envy you at all. But that's just like the feedback that we get from our community, is those that kind of are mentally better prepared in terms of what to expect. Maybe more so in senses, then function, cope better, and are less scarred by the experience in the long term.
So that is really useful, and that is something I can take back to my community. Absolutely. And I think, yes, with the tracheostomy, knowing that you can cough the secretions out, that the sound is a lot of the time a lot worse than the reality. So this airway is a safe airway because we can suction it. You can cough through it, but it's exactly as you say, that swelling above your mouth, in your mouth as well, means that you need the tracheostomy because you can't get air in and out of your mouth easily as well, is the other reason. So you're so vulnerable.
And you've got a tube in your mouth, in your nose. And then there's another tube somewhere as well.
And you've got drains,
drains
absolutely.
And the Doppler
and everything hurts, and you're so vulnerable. And actually, it's a really great thing because we can really think about describing what that's like so we can do better, because we can always do better. Absolutely.
Amazing. Oh my God, where has this hour gone? Gemma, it's been such a delight to have you on. Thank you so much. I have a feeling we're going to have you back at some point.
I'm always happy to come back.
Thank you so much. And I really enjoyed it. And thank you for all the work you do as well. And I know you're always on the research front. So hopefully we'll have you back with a report on other work that you're doing.
Absolutely, I'd be really happy to. We've got some really exciting research projects coming up, so I'd be really happy to share those with you.
Amazing.
Thanks so much for having me.
Thank you so much, and thank you to our listeners. We are coming towards the end of season 2, but don't worry, we've got a couple more episodes left for you to get you through the summer. So stick with us, and we will see you next Friday. Thank you. Bye-bye. Bye.